I'll switch gears very quickly. Testicular cancer screening. If you're coming to my office, you're going to basically get a physical examination. That's my screen. I don't do ultrasounds on people routinely unless I feel something abnormal. Bladder cancer screening. So bladder cancer, we screen anyone for bladder cancer if there's either microscopic blood or gross blood in the urine. Just because somebody comes in and says, well, I got a family history of bladder cancer, we don't start screening them. Most bladder cancer is caused by smoking, and patients are blown away by this. They can't understand it. I said, you smoke, and they say, well, I thought you just get lung cancer. All the carcinogens, all the junk goes into the lungs, gets filtered into the blood. Blood gets filtered by the kidneys. All the carcinogens sit in the urine. They basically bathe the lining of the bladder in all these carcinogens, and most people get tumors in a dependent portion of the bladder because the urine with all the carcinogens is just sitting there bathing the wall of the bladder. So if you have microscopic or gross blood in the urine, you're going to end up getting a CAT scan of the upper tracts, abdomen and pelvis of the kidneys, looking at the ureters. You'll have me put a small scope inside of your bladder as well and take a look around, and we send urine for cytology. So you get screened. It's not like colon cancer where everybody's going to get screened. If you have blood, you get screened. And then screening for renal cell carcinoma, and on the list of cancers that David put up, so after prostate and lung and then colon, number 4 on there is bladder cancer. So 55,000 new cases a year of bladder cancer. And 200,000 new cases of prostate cancer a year. Divided by 7,000 urologists in the United States. It's my volume that I see of cancer is huge, and it's a lot of what we do. Renal cell carcinoma. Don't routinely screen people for renal cell carcinoma. If people come in and they say, hey, I have first-degree relative, I will get an ultrasound of the kidneys. Completely easy, non-invasive. You rub a wand on their back. It's a very good study. Assuming that their body habitus is reasonable, you can get a lot of information from that. Most renal cell carcinomas that I see, and Iran could tell you this, I'm sure, and I've seen patients referred from Coordinated Health, and I've looked at an MRI of the lumbar spine read by Iran Mandelker, that the kidneys were incidentally visualized on this study, and there is a cyst. It's indeterminate. We cannot be sure what it is. Further testing and evaluation is recommended. So the large bulk, the vast majority of renal cell carcinomas, renal masses that I see are incidentalomas that we call them, and it comes from having another test done for another reason. They then get referred to me. The study of choice that I like is a CAT scan with contrast or perhaps an MRI. So that's kind of screening on other genitourinary malignancies. Any other questions about that? Otherwise, I'll switch gears quickly and talk about testosterone.
So the patients with Lynch syndrome or HNPCC that are at risk for high urothelial cell tumors, do you follow the same path? You do cytology, or you do a UA, and in the absence of blood, you don't do anything, or you send cytology and? If
they're high risk, I'll do a UA and I will do possibly a cytology. I'm hard pressed to do cystoscopy. There's not a whole lot to say do cystoscopy on somebody unless they really have blood in the urine. But if they really wanted to know, I will do it. And again, it's very easy. A lot of primary doctors, and I'm not putting them down because it's statistically it's what you're going to find. But young woman comes in and she's got blood, and everyone thinks it's an infection, and they get rounds of antibiotics, and eventually I'll put a scope in that person. And I can tell you, I had a 33-year-old in my office within the last 6 months who had a very large bladder tumor. She had no chemical exposure. She had never had a smoking history. She came in with her husband. She was an absolute wreck. They have 3 little kids, all under the age of 7, and she was a wreck about it. The good news about bladder cancer is the vast bulk of bladder cancers are managed very simply with cystoscopy in the operating room. You go in, you find the tumor, and you pluck it out, you cauterize the base, and that's it. Unless they're deeper tumors that invade more into the wall of the bladder, or they're recurrent tumors, or they're high-grade tumors, or there's carcinoma in situ, then those patients are needing more treatment and more follow-up. Jane?
In your practice, the men with the prostate cancer in that gray area where it's a lower grade, they're
Sure.
a little older age, they're in their early 70s, and you just want to watch it and do your biopsies. Do you find that you have a lot of patients who have the attitude that I have cancer, I don't want it there, I want it out?
Sure, and that's hard to argue, and I say, oh no, you don't need to have a radical prostatectomy. The studies say that you're going to be fine, and people say, I don't care what the studies say. I have cancer in my prostate, please take out my prostate. And where I'm doing that more aggressively, because it didn't fall under the study guidelines that were recently released, is guy comes in, he's 52 years old, and he has small volume Gleason 6 cancer. That guy, that's a different story, because in time, you know, fast forward 20 years, that guy's only 72. He'll have trouble from that cancer. So it's kind of like doing it almost a preemptive strike in those guys. All right, I want to switch gears very quickly and talk about testosterone deficiency syndrome. I was telling I think it was like my first week in practice. And a guy comes in and I said, why are you here today? And he says, well, I'm lethargic and I have weight gain and my sleep is not good and I'm irritable. And you know, I'm just graduated residency and I'm like, depression, this is depression. And then he says, well, my primary doctor did a testosterone level and it came back low. And I was like, testosterone level? And I was like, And I remember I excused myself from the room and I started to go look up low testosterone. And I'm like, this is really bad. Here I am in practice a week and I'm supposedly, you know, board certified in urology and people are coming to see me about something I have no idea about. And so when I think back in my residency, I didn't have a single lecture on low testosterone. I never saw a patient in the clinic that I could recall with low testosterone. And I never wrote a prescription to replace someone's testosterone. So here I was faced with what was eventually going to be the floodgates opening of testosterone, of low testosterone, low T, and testosterone supplementation. And a lot of that force has been just driven by the media lately. You can watch TV now, and there's commercials for androgel and Testim, and you name it, all these ways that we can replace testosterone. There truly is an effect on the population. They come to my office and say, hey, I saw a commercial, or I was in your waiting room, and I read this thing, and I think I might have low testosterone. Can you screen me for this? So testosterone deficiency syndrome exists. It's a clinical and biochemical syndrome, often characterized with advancing age, or seen with advancing age, and characterized by basically a decline in serum testosterone. You know, talking about testosterone and something made by the gonads that, you know, sort of had all of these effects goes back to antiquity. But it really wasn't until the 1930s when testosterone was identified. And in 1939, two European scientists actually won a Nobel Prize in chemistry for basically synthesizing testosterone. The epidemiology, it's quite prominent. About 12 in 1,000 men in the United States will have testosterone deficiency syndrome. Upwards of 400,000 to 500,000 new cases in the United States a year. And we're not talking about congenital things like Kallmann syndrome, which is failure of GnRH, or Klinefelter's 46XXY, things like that that have low testosterone. Regulation of testosterone, hypothalamic pituitary axis. The GnRH is secreted from the hypothalamus, goes to the pituitary, tells the pituitary to secrete LH. LH is luteinizing hormone. Luteinizing hormone goes to the testicles, acts on the Leydig cells, which cause increase in testosterone. So what happens as you get older? Well, anywhere in that axis there could be disruption. Low GnRH, low LH secretion, adequate LH secretion but low number of Leydig cells. Adequate LH secretion, adequate number of Leydig cells, but failure for that LH to activate the Leydig cell to make testosterone. So there's still a lot of unknowns out there about what causes hypogonadism or low testosterone. But aging is postulated to affect this axis. So there's a lot of reports in the literature about a close association with low testosterone and metabolic syndrome. Saying that testosterone can improve insulin action, it can decrease glucose levels, it can reduce abdominal fat. The problem is there's not a lot of great studies out there that have shown this to be, you know, the fountain of youth that we all thought that, or not we all, but that many urologists or endocrinologists thought that it would be. Basically, testosterone can be found in a couple forms in the body. It can either be free, which is the active form. It can be bound to albumin, which is a semi-active form, or it can be bound to a sex hormone binding globulin, which is a completely inactive form. And again, as you get older, maybe there's a stronger affinity for the SHBG, the sex hormone binding globulin, to hold on to testosterone. And so there are so many different places in the endocrine system where you could have a failure here. But we do look at total testosterone and free testosterone when we test. So what are some symptoms? Decreased energy, decreased libido is huge. Erectile dysfunction, decreased motivation, irritability, inability to concentrate, weight gain, hot flashes, muscle aches. So again, you could be describing depression. You have to rule that out. But that's classically how guys come in. I do a physical exam. I look at their testes. Not all of the testicles are atrophic or small. You can certainly have primary testicular failure and still have a normal size and volume of testes. And even, when you read, and I was preparing for this, they talk about decreased facial hair or pubic hair or sarcopenia or muscle wasting. I don't really see that. In general, and I'm kind of, this is anecdotal, the guy that's coming in is 48 to 55. It seems like he lives a very sedentary life, definitely overweight. They talk about just decreased energy. They can't beat the weight. They fall asleep after meals. They can't stay awake at night. So how do we diagnose it? Well, we check a testosterone and a free testosterone level. The other thing that I do as well, and even just looking at the literature, I didn't see a lot on doing it, but I do it routinely, and I've seen 2 patients that have had trouble with this. I send a prolactin level. So at the level of the pituitary, if you have a pituitary adenoma or a pituitary mass that will secrete prolactin, that will drive down your testosterone level. So I've had 2 guys who've come in, they give me these symptoms. One guy was really young. I said, you know what, something's not right. His prolactin level was sky high. I sent him for an MRI of the pituitary, and it came back as a adenoma of the pituitary. And then he went on to get treatment for that. So you don't want to miss something like that. So how can we treat it? How can we treat this? Well, there are some very good treatments out there. One of the problems is that there's really no oral formulation. And the issue is that I can never memorize it, and I always try to look at it before I talk like this, but there's that classic diagram where you have cholesterol going through all the different enzyme levels, and it tells you what it goes into. And because of first-pass metabolism, if you take an oral formulation of testosterone, it will go to the liver, it will be broken down immediately into basically a cholesterol ring, and it will be degraded from the active form of testosterone. So you can't take oral testosterone. There are some forms available, not in the United States, some in Europe, and some have very well-known liver toxicity, so they're not allowed here in the United States. But you have a couple options. There's injectables. There's a every 2-week injection, an IM injection you can get. There's a slow-release pellet. There are buccal tablets that you can put in that will dissolve. But the most common thing that I use in the office is either a patch, and probably more so is the gel. And basically the gel comes out, looks and smells like Purell. 2 pumps. It's an alcohol base. You rub it in on your arms and chest. I always remind men, don't put it down there. Just put it on your arms and chest. You can't have contact with women or children because it's transdermal. Until that dries, the partner or the child or whoever you touch, they can pick up testosterone on their skin. So you really have to be careful about that.